oxygen therapy sources and the delivery system and monitoring of the oxygen saturation.
Good afternoon, everyone. Now I'm going to tell you something about the oxygen therapy, oxygen sources, and oxygen delivery and monitoring in a patient with COVID-19. As we are seeing that the coronavirus has rapidly spread and swept across the entire country worldwide, and all of it there will be panic, lot of panic, and people are trying for self care under home quarantine also. So now oxygen therapy has been widely and strongly recommended for the patients in hospital and cabin hospital in China. However, asymptomatic patient or mild COVID-19 has not been given a sufficient consideration in the present therapeutic guidelines. But the problem is with COVID-19 is that we have to prevent thus progression of disease from mild COVID-19 to moderate to severe. So there comes the role of oxygen therapy. Most of the patients with mild COVID-19 are managed on the basis of home quarantine and home isolation. Now, looking over the active cases who are requiring critical care, as we can see in this graph that 93.63% of the active cases requires a normal care. That means they require just home isolation and home quarantine. Then 6.33% active cases, these are requiring critical care. Now, in this critical care group, 2.94% patients requires ICU monitoring and 2.94% requires oxygen support and 0.45% requires ventilator. Now, important point is that why we need early oxygen therapy in a patient with COVID-19. This is because there are 4 points I want to emphasize on that it disrupts the viral replication by decreasing hypoxia inducible factors, which is then thereby it inhibits glycolysis, which is needed for the replication of virus. The same pathogenesis is seen in other viruses along with coronavirus, with HIV viruses and with other adenoviruses like dengue. We can see this method. Now, the oxygen therapy can prevent accumulation of lactate also by increasing its degradation and preventing the release of type 1 interferon and activating the antiviral immune response. Now, third point is it reduces the upregulated expression of AC2. AC2 is basically a receptor to which the spike protein binds. So if the expression of AC2 receptor will be low, so the chances of viral protein, the spike protein binding to the our cell membrane will be low. Now, the new studies are going on that says that nocturnal oxygen therapy may delay the progression of COVID-19. Why? Because we see that in COVID-19 the main problem is cytokine storm, which is due to the factors like TNF alpha, interferon gamma, IL-6 and IL-2 and IL-12. We can see that just like the cortisol, these cytokine storms also have a nocturnal rhythmicity. That is, it peaks at night and early morning when the plasma cortisol is lowest. Now, that is all about why we need early oxygen therapy. Now, what are the oxygen sources by which we can use? We have oxygen cylinders which can provide 10 to 15 liters of oxygen per liters, and oxygen wall outlet which we see in our hospital also. And now there is also oxygen concentrators which is for the home use. It requires electricity, can give oxygen 5 to 15 liters depending on the capacity of the machine. Now, oxygen delivery devices are basically of two types. One is the low flow and second is the high flow device. Low flow just means that the flow is less than the inspiratory flow, while the high flow devices have a flow which is more than the inspiratory flow. It has a fixed performance. Now, I will tell you about some of the methods by which we can give low flow oxygen. First is the nasal cannula, which we mostly use and the flow rate is 1 to 6 liters per minute. But the most disadvantage is that it can easily dislodge. If you apply it to the patient, it can easily dislodge. And if you give more than 6 liters per minute, it increases the dryness of the nasal mucosa, which will cause stuffiness. But advantage is it is easy to use. Any patient can use it and perform his day-to-day activities. But the oxygen which is provided with this nasal cannula is just between 24 to 44%. We can't give above that. Now, the simple face mask, the flow rate has increased, that is 5 to 10 liters per minute, and FiO2 can be increased to 35 to 55%. But the problem is that when you apply a face mask, patient may have some claustrophobia and he can't eat. And you should always ensure that the exhalation ports are free and strap is adjusted properly. Now the next is the non-rebreathing face mask. The flow rate has, now we can increase the flow rate up to 10 to 15 liters per minute, and FiO2 we can give up to 95% FiO2, that is 60 to 95% FiO2. But the most problem is with that, there can be CO2 retention and patient may aspirate. So basically we use non-rebreathing face mask in those patients who have spontaneous breathing but there is severe hypoxemia and the patient is fully oriented, conscious, then only we can use the non-rebreathing face mask. And your reservoir bag which is present beneath the face mask, it should be inflated. Then the Venturi mask. Basically we use Venturi mask for COPD patients only, not for other patients, because it has different color codings, and according to the color coding we provide them different amount of oxygen is supplied. High flow nasal cannula is a newer technique, and it is recorded that high flow nasal cannula is better in requirement of the NIV for invasive ventilation is less in the patients who are provided high flow nasal cannula in early stages of the disease, and it is a very high flow rate, that is 60 liters per minute. It consists of an oxygen blender, a humidifier and a nasal cannula. Through high flow nasal cannula we can deliver FiO2 up to 100%, but it is costly. In our hospital it is available. Then the CPAP mode. CPAP mode basically it provides a constant oxygen flow at a prescribed rate, but with CPAP mode the patient should be properly conscious. We can't use CPAP mode in a patient who is not conscious, who is not cooperating. We can't use CPAP mode. Its advantages: it prevents alveolar collapse and improves oxygenation and minimize the requirement for NIV. Now we can see in this diagram that in a normal ward patient we can use a first step is using the nasal cannula. Second step is using the non-rebreather mask. If patient can't tolerate all this, then you will shift the patient to HDU or ICU. And the step 3 is continuous positive airway pressure therapy. And step 4, when he can't cooperate with the CPAP mode, then you will go towards the invasive mechanical ventilation. With invasive mechanical ventilation, the survival rate is reduced, that is just 30% survival rate. Now, in short, I will tell you how will we deliver the oxygen in an adult patient according to WHO guidelines. First of all, start at oxygen with the help of nasal prongs, that is 5 liters per minute. Assess the patient. If the SpO2 is not improving and he is having tachycardia, restless, then you can increase this oxygen level by using face mask, that is 6 to 10 liters per minute. Then again reassess the patient. You can now use your face mask, but non-rebreathing face mask, which consists of a reservoir, and you can give oxygen up to 10 to 15 liters per minute. If the patient is not maintaining well and the SpO2 is still less than 90%, now in a center where there is non-availability of tracheal intubation, immediately transfer the patient to a hospital, tertiary care center, where you can provide him a tracheal intubation. Always monitor the emergency signs, that if there is severe respiratory distress, central cyanosis, and if the patient is in shock or there are any signs of severe dehydration, that means patient is lethargic, patient is sunken eyes, very slow return after the pinching skin, then always refer to the patient to a tertiary care hospital. Now the last thing which I want to conclude my session, that is the clinical guidelines on oxygenation therapy. Maintain target SpO2 between 92 to 96%. Close monitoring of vital parameters, SpO2. Now look for the labored breathing and breathing pattern of the patient. Neurological assessment throughout the process is required. And now the latest guidelines in COVID-19 is to start NIV as an initial therapy rather than the invasive ventilation. We will prefer high flow nasal oxygen cannulas and CPAP. But when you give CPAP, always, for a healthcare worker, always try to minimize the spread of aerosol generation and follow the universal precautions. ABG sampling to be done every 1 hour after the initiation of therapy. Repeat sampling if depending on the clinical status of the patient. Minimal interruption in NIV for activities. And there was a trial for awake proning also, but it should be used only in a patient who is hemodynamically stable, not in a patient who is unstable. In severe cases, intubation should be considered. Now summary is that with ending is this, that we need to maintain the SpO2 more than 94% in every patient and titrate it accordingly. In pregnant female, we have to be more precautious in maintaining oxygen therapy. We usually in adults we start oxygen support at 5 liters per minute. In children's we start at 1 to 2 liters per minute using cannula. Never give high flow oxygen patient in a patient who is having type 2 respiratory failure or who is unconscious, not following commands. Then you should prefer your invasive ventilation. That's all, ma'am.